I think there's one or two people still joining the meeting, but I think the majority have managed to join. So welcome to the meeting this evening. As it says, it's cholesterol, and try to empower you to understand both what you can do and what you should be expecting from the system, from your doctors, nurses and healthcare professionals in terms of helping and supporting you. I'm Pete Green, I'm a GP, I'm chair of Heart UK, and we've a range of speakers tonight presenting. We're hoping to be able to cover off most of the questions that you've sent in through the presentations. Equally, we'll have a bit of time to cover off some questions towards the end of it. And we will look after the meeting to see if we can respond to any questions that people are on. Obviously, we can only be giving more generic advice. We can't be delving into individual patients and individual concerns on that. But having said that, so welcome very much, and I'll hand back to Jamie.
Thanks, Pete. Hi, I'm Jamie Rind. I am the Service Development Manager with Heart UK. Just to let you know that this webinar is being recorded and will be submitted, loaded up onto our website. And this evening we welcome all your questions. We've had lots of questions in during the registration process, but please feel free to use the Q&A section at the bottom of your screen to submit any questions that you would like to our individual panelists. Or we also have an extended Q&A at the end of the webinar, where we will also be doing our best to answer your questions. This webinar marks 20 years since the formation of Heart UK, the merger between the Family Heart Association and the British Hyperlipidemia Association. The organisation, the charity, was formed with the single vision of ending early death and disease from cholesterol and other blood fat conditions. And our mission is for people to know and understand their cholesterol levels and blood fat levels and to take appropriate action. For some, that action might be diet and lifestyle changes. For others, medical treatment and medication may be required to manage lipid levels. But knowing what action is appropriate or even possible isn't always easy. So we hope that being part of this webinar tonight will help provide you with a better knowledge and understanding of some of the important aspects of cholesterol and blood lipid management. So without further ado, we're incredibly fortunate to be joined by really some exceptional lineup of speakers this evening, all of whom are leaders in their respective fields. So without further ado, I'd like to introduce you to our first speaker, Jules Payne. So Jules is Chief Executive of Heart UK and has over 18 years experience in the charity sector. Since joining Heart UK back in August 2010, Jules always has patients and their families at the heart of everything that she does. She's extremely driven and passionate about Heart UK's support and education and our influencing services. And as these activities raise awareness and provide support to millions of people each year, and most importantly, save lives. So Jules joins us to talk about how the landscape of lipid management has changed over the years of Heart UK's existence. Jules, over to you.
Thank you very much, Jamie, and welcome everybody. It's lovely to have you with us this evening. So as Jamie says, Heart UK is 20 years old, and HEART is actually an acronym. It stands for Hyperlipidemia Education and Atherosclerosis Research Trust UK. So therefore Heart UK is so much easier for everybody to understand, and then adding on the cholesterol charity just makes it even clearer exactly what we actually do. We are an unusual charity because we provide services, all of our services, for both the patients, the public, as well as the healthcare professionals treating those patients. So this is very important to us. I'm a great believer in charities should set themselves up, resolve the problem, and then the charity doesn't need to exist anymore. Sadly, we are some way from that. So whilst we're celebrating 20 years this evening, I think it would be nice by the time we get to 30 or even 40 years, we will have resolved it. Things don't move very quickly within the system. So what Heart UK is all about is lowering cholesterol and saving lives. And this is just what gets us up every morning. We actually do that through our, as Jamie has said, through our awareness raising and through our support, education and influencing services. So we work really, really hard to keep cardiovascular disease and lipids as a top health priority for the government and the NHS. And over time, we've seen that sort of ebb and flow, with one time it may be a priority and then 6 months later it's not even being discussed. So this is what we've worked on over the years, to try and keep that conversation at the forefront of the conversations, to make sure that we are actually addressing prevention. Is a big, big word, that actually it is that needs addressing with cardiovascular disease. We need to find people as early as we possibly can. So basically we work with the system, so with the NHS, but we also hold it to account. And we've done that in many ways over the years. We publish many reports that then we use those reports to have engagement with key stakeholders that could potentially overturn a policy and turn it from a negative policy into a positive policy. And that happened with the armed forces. If you had familial hypercholesterolemia, the genetic form of high cholesterol, you were unable to go into the armed forces. But we worked with the system to overturn that policy, and I'm pleased to say that now, if you wish to go into the armed forces, there are requirements, but it's not a strict no, you cannot go in. So there's many things that we've done that we've had huge success with, and we work with the system, but we also work with our ambassadors and the public to help us to overturn this, because together we can make that really big difference. We want to make sure that we are empowering patients to take control of their condition, and that's key. It's, as well as the healthcare professionals needing education, the public also need education, and it's about working together in all of this and coming together to really improve the health of the population. So we are at all the top tables in terms of where high level discussions are being had around cardiovascular disease and lipids. We are at those tables, making sure that we are representing the patients that we actually have a voice for. And I'm a great one for thinking that the C in cholesterol often stands for Cinderella. As I say, there's ebbs and flows over time in terms of whether it's a priority or whether it's not. But of course, it's a priority to you all the time. If you have high cholesterol, then you need the help when you need the help. And that's exactly what Heart UK is here to help you with, to make sure you get that help, to make sure you have the information and support that you need on your journey to future health. Back in 2013, the NHS published a CVD outcome strategy, and I was hugely proud because every meeting that we turned up to, one of our ambassadors was speaking, and basically that led to FH being included in the outcome strategy. That led on to, in 2019, the NHS long-term plan was published, and cholesterol and FH were both featured with targets. This is really important. So those targets now, we are holding the system to account to make sure those are delivered. They have slipped a little, but we will keep that pressure on, and we will keep the pressure on for exactly what we also need. So we need national and local strategies for CVD. We need incentives for healthcare professionals. We need data. We need diagnosis, so we need testing. We need joint decision making, as I've talked about. And we need follow-up for patients that have had a heart attack. And of course, data comes back to how we're going to resolve all of this so we know where we're at. But we need an empowered patient to actually help the system to help them. So that whilst I can talk about Heart UK forever, and I can see that I've had my indication I need to finish my talk, thank you, Jamie. Basically, it's just quite simple. Let's work together to crack cholesterol, and then we can all live a long, healthy life. And just, can I ask you, you'll all know about the services that we provide, but if you wish to become an ambassador and help us to help you have a voice in your local area, please do get in touch. Thank you.
Thank you, Jules. Jules mentioned the condition familial hypercholesterolemia a couple of times in our talk, and it's probably a condition that many of you will be familiar with, the inherited condition that affects around about 1 in 250 people, and it basically means that it allows high cholesterol to build up in your blood. Left unchecked, this can be life-threatening. However, with effective management, it does allow those with the condition to lead largely unaffected lives, as our next speaker will duly demonstrate. So I'd like to introduce James Dobson. He's an ambassador for Heart UK, and is currently working towards his master's degree in chemistry as a postgraduate researcher at the University of Cambridge. He is also an FH patient, and will be speaking to you today from a patient's perspective. James, over to you.
Okay. Thanks, Jamie. So I'm just going to give you a bit of an insight from a patient's perspective, as many of you will be. And probably most of what I say will be mostly relevant to young people, particularly those in early teens, so possibly some of your children, those that have been recently diagnosed with FH, and also those that are either thinking of getting tested or are related to someone who has been recently diagnosed. So I was diagnosed 8 years ago, which seems ages ago, back in 2014, which is just done by a simple blood test. And I was actually tested alongside my brother, but luckily he doesn't have FH. And this was all done off the back of my dad being found to be FH positive as well. So as Jamie said, there's around 1 in 250 people in the UK that are suspected to have FH. So that makes me and my dad two of the 220,000 people in the UK which have FH. And what was weird was that at the time, as a fairly active 13-year-old playing lots of rugby and cycling, cholesterol levels are definitely not something that you think about, and are probably something that I didn't even know what cholesterol was at the time either. So to find out that my cholesterol level was 7.5, which is nearly double what it should be at just 13 years old and skinny and 50 kilos, was a bit of a shock, which is understandable. But I think it's important to discover these things early so that you know what you can do to treat and manage the condition. So after the diagnosis, I was prescribed a 10 milligram statin to take daily, which was atorvastatin. And my doctor informed me to just, at the time, essentially just keep doing what I was doing. So keep exercising, but pay more attention to my diet, looking for foods that are low in saturated fats. I think especially I was mentioned foods below 1.5% saturated fats was sort of the area to aim for. So off the back of that, 3 of my cousins on my dad's side were also tested, but only 1 in 3 of those were found to be positive for FH, which is better than we could hope for. But the reason I've mentioned all this and with the young people stuff is that compared to my dad, I was kind of lucky in a way to find it when I was 13, because by making the changes now, I reduced the impact of the disease later on in life. And that's what I can say to you guys as well, especially those that are either on the fence about being tested, or if you know someone that you're related to that has just tested positive, then please do take the time to get yourself checked, because it doesn't take long. And it's important to do for 2 reasons. The first being that accessing the treatment as early as possible reduces the impact on your heart and your arteries later on in life. And also it allows you to make the changes to your lifestyle, avoiding things like smoking and fatty foods, which are all fairly easy things to do once you know. But I think also, especially for those of you that have children that have just tested positive, I think the main thing is don't worry or try not to worry, which is something I probably could have done with hearing at the time. Because although this condition is serious and there's nothing to take away from it, it really is quite a treatable and very easily managed condition. And I always think it could be much worse. There are far worse genetic conditions out there. So getting tested now and making the changes as early as you can is the best thing to do. And it certainly isn't a debilitating condition either. It's not going to hold anyone back or anything like that. So yeah, I hope that insight was helpful, and I'll pass back to Jamie.
Thank you, James. Yeah, really interesting to hear about your own experience of living with FH. We've heard it's an inherited condition caused by one or more faulty genes. So therefore, FH naturally runs in the family. Hence the reason why it's vitally important to ensure that, when a case of FH is suspected, the patient does get genetically tested to confirm the presence of that faulty gene. Now I'd like to hand over to somebody to talk to us about FH and genetic testing. So Lisa Gritzmacher graduated in nursing in 1988. She won't mind me saying. Although you won't believe it. So going on to work in coronary care and cardiothoracic units for over 20 years. In 2014, Lisa undertook the role of FH clinical nurse specialist, setting up a regional cascade screening service across Bristol and Bath. Lisa works with a variety of organisations, both locally and nationally, to deliver a regional integrated service towards the goal of achieving a nationwide linked-up cascade screening service for people with FH and their relatives. Lisa, over to you.
Hi, thanks, Jamie. So as Jamie said, I'm going to talk about FH and genetic testing, and we abbreviate familial hypercholesterolemia to FH because it is quite a mouthful. So familial hypercholesterolemia, as we've already said, is an inherited cause of high cholesterol, as opposed to general population causes such as diet, lifestyle, increasing age, and what we call secondary causes, for example, certain conditions like thyroid problems. And as we've also alluded to, it's very common. About 1 in 250 of the population has it. And it's caused by an alteration in one of 4 cholesterol genes that we all have. So think of it as a significant spelling mistake or misprint in that gene, such that the instructions in the gene no longer make sense. So it's not like a small typo where you can still read what a sentence says. This is like a really significant spelling mistake, such that that sentence is a load of gobbledygook. It just doesn't make sense. And that means that the gene can no longer do what it should, which is code for, provide instructions for, making certain proteins. And these proteins that the genes make, the cholesterol genes, they remove the bad cholesterol from our bloodstream and take it into the cells of our body, and this helps regulate our cholesterol levels. So each cholesterol gene plays a slightly different but crucial part in the process of removing the bad cholesterol from our bloodstream. And therefore, if one of the cholesterol genes isn't functioning because the instructions don't make sense due to that misprint, then your cholesterol levels will be higher because you haven't got as many proteins helping to clear the bad cholesterol from the bloodstream. And this is why with FH, no matter how good your diet and lifestyle is, it's not enough on its own to treat your cholesterol levels. So you can't fix that spelling mistake, that misprint, with diet and lifestyle. They're very important. And if you have a poor diet and lifestyle, obviously your levels will be even higher of cholesterol, but it's not enough on its own. You do need the treatment alongside it. And we now have genetic testing to look for gene alterations in the cholesterol genes to find out if someone has FH. If we find a gene alteration known to cause FH, this confirms a diagnosis of FH in that person. And as previously said, this is just done by blood test. And this first person that's diagnosed with FH in any family is called the index case. And because this is a genetic condition, it can be passed down through families. And also because it's genetic, you are born with it. And this means that you will have raised cholesterol levels from birth. So immediate relatives of somebody with FH, and we call those first degree relatives, and that's parent, siblings, which is brothers and sisters, and children of someone with FH will have a 50% chance of also having this gene alteration causing FH. And this is important because if FH is left untreated, it can lead to early cardiovascular disease. So by that we mean heart attacks and strokes. Sometimes as early as the 30s or 40s, but commonly before the age of 60. However, if it is treated early on in life, we can almost eliminate the risk of cardiovascular disease associated with FH and bring that person's cardiovascular risk back pretty much to that of the general population. And by early on in life, we actually mean in childhood, at about 10 years of age. And this is because the younger you are when you're identified and treated, the longer proportion of your life will actually be spent with normalized cholesterol levels because of the treatment that you're on. And this therefore reduces the risk of cardiovascular disease associated with FH. So we kind of have a saying that's you inherit the condition, not the heart attack. So if you're treated early on in life, then that risk is managed. In reality, of course, we don't always identify people that early in life, but we do aim to identify them at the earliest possible opportunity through things like family screening and other screening mechanisms, and offer treatment if they have FH. And there is still huge benefit to identification and starting treatment, even at much later ages in life. And this is because the treatments that we have are so effective at reducing cholesterol and reducing the risk for cardiovascular disease. Once we know someone has an FH gene alteration, we can then offer a targeted test, a genetic blood test, to their relatives. And this looks in that specific gene that the index case individual in that family has, in that one spot where we know there's a misprint, the gene alteration, to see if that relative also has it. If they do, this gives them a diagnosis of FH as well. So this is actually much quicker in terms of getting the result and cheaper than the initial index test because we know what we're looking for. And we call this process of testing relatives cascade testing. So who should have genetic testing? Well, individuals that are suspected to have FH, and this is based on their cholesterol levels and family history. And there's a process that we go through to determine this. So we consider FH in people who are found to have high cholesterol. By high cholesterol, we mean a total cholesterol of 7.5 or more, and the bad cholesterol, LDL cholesterol, of 4.9 or more in adults. And they may also have had heart disease under 60 years of age. And in the context of FH, the heart disease that we mean is things like angina, maybe stents, heart attacks, or coronary bypass surgeries. And that's along with, and it's really important that the individual's history is along with a family history of other relatives who may also have high cholesterol and possibly premature heart disease, which is when it occurs under 60 years of age. People might also be identified as possibly having FH from GP system searches as well. The NHS is encouraging this to improve the rate of identification of FH. So you could be contacted by a GP to be referred in for this FH assessment if they've done a search for people and you fit some of these criteria. Once we have somebody with high cholesterol, we think, oh, is this FH? Then we first need to rule out some other secondary causes or possible causes of high cholesterol. So things like, is it diet and lifestyle driven? Is another type of blood fat really high, which is triglycerides, and another speaker will speak about that more later, but these are normally usually normal in FH, and other conditions like thyroid problems. Or anyone actually who's previously had a really normal cholesterol level or a low cholesterol level, because FH is characterized by lifelong raised cholesterol levels. So if you've previously had a very normal cholesterol level, then it's unlikely, even if it's raised later in life, that that's due to FH. And then we use certain scoring criteria to guide the decision on whether the information collected about that individual and their family history means it's likely that they do have FH, and therefore if we should go ahead and offer genetic testing. And this initial genetic test for the index patient looks at all 4 cholesterol genes that we have. So once someone is diagnosed with FH through this index test, then all their immediate relatives should also be offered genetic testing, regardless of their cholesterol level, or what we refer to as a lipid profile, and regardless of whether they're on treatment or not already. And this is different, obviously, to that first person tested in the family, because we know FH runs in that family now, and therefore we know their relatives will have a 50-50 chance of having it. And this process should actually repeat each time someone in the family is found to have FH. So each time an immediate relative is confirmed to have FH, then their immediate relatives should also be offered genetic testing. So it cascades out through the family. So how might you access testing? Well, for individuals suspected with FH, based on your lipid profile, cholesterol levels, and family history, that will be through a GP referral to a lipid clinic or FH service for that FH assessment and process that I've just talked about. If you think that this picture fits you and your family history, then you can discuss that with your GP and see if maybe you should be referred. In the future, it's possible that this initial index test, genetic testing, might be done in your GP surgery, but we're not there yet. There's a lot of skills and knowledge gap that needs to be filled, and also a lack of resource and capacity at the moment in GP surgeries to do this before this can be rolled out in primary care. If you're a relative of somebody who's already been diagnosed with FH, then access to testing is through that individual, that index case individual that was first tested in the family, and the lipid clinic or FH service that actually tested them. And this is maybe through a couple of different ways. So we say either through indirect contact or direct contact. And indirect contact is where the index relative will actually provide information to you in letter form about the FH testing that is being offered. Direct contact is where a letter about that testing process comes to you directly from the service, where the index case has actually provided contact details for this purpose. And this may require a GP referral to your local FH service or lipid clinic to get tested. But in some cases, relatives actually will be able to self-refer to their local service. And if that's the case, that information should be available in the letter so that you know which way around that is. Relatives under 16 should also be referred to paediatric clinics, but another colleague will talk about that later. And these pathways are generally more applicable to people with heterozygous FH than where people just inherited one altered gene, than homozygous FH where they've inherited two altered genes, because people with homozygous FH are often seen and managed separately in very specialist clinics. So I'm now going to hand back to Jamie.
Lisa, thank you. And apologies to anyone that couldn't see Lisa during that presentation. I didn't want to interrupt your flow, Lisa. But,
my video's not working.
I hope
no,
that,
sorry, I do apologise about that.
I hope that everyone still found that as insightful and useful as I certainly did. So so thank you very much for that. As we've heard from James and from Lisa, high cholesterol can be something that we are predisposed to, and from a very young age. So identifying and treating young children, it can be challenging, but the earlier they're identified, then the earlier that condition can be managed, limiting the impact of excessive cholesterol. So here now to talk about high cholesterol in children and young people is Lorraine Priestley-Barnham. Lorraine is a clinical nurse specialist for paediatric FH at Harefield Hospital in London. Lorraine has worked in cardiorespiratory nursing since she qualified as a paediatric nurse from Great Ormond Street over 20 years ago. Her role involves the identification and management of children, of young people and adults with FH. She's a nurse representative on the National Paediatric FH Steering Group and is passionate about empowering and educating families with the right knowledge and tools to manage their FH. Lorraine, over to you.
Super, thank you, Jamie, and good evening, everyone. We're absolutely delighted that you've all been able to join us here this evening. As Jamie has already mentioned, I'm here to tell you a little bit about caring for children and young people with high cholesterol, or FH. And I do hope for the parents amongst you that you've already taken some comfort listening to James and his very humble extract of his life experience of somebody who's living with FH and who's fulfilling a very normal life. So that's really good. And thanks so much, James, for doing that. As most of you will know, FH stands for familial hypercholesterolemia, or as we say, a family history of high cholesterol in your blood. And as a parent, if you have a genetically confirmed diagnosis of FH, then there's a 1 in 2 chance that your child would have it too. And that's why it's really important that they get tested. FH is not a life-limiting condition, as we've already heard now a few times, providing you know that you have it. But the problem with FH is that it's massively underdiagnosed in the UK. And with our current birth rate sitting around 700,000 births per year in the UK, we're estimating that 2,500 children are born each year with FH, but we're nowhere near identifying all of those children. So it's really important that we all raise awareness of FH and find these children and get them on the relevant treatment as and when is necessary. So if you're an adult parent, if you're a grandparent and you're listening in this evening and you're taking statins for high cholesterol, or you know you have high cholesterol, it's also worth contemplating if you might have a genetic diagnosis of FH, and that's something that may have never been previously considered by whoever manages your cholesterol. So maybe have a listen to the presentations this evening and think about whether you meet the criteria for genetic testing, which Lisa has already spoken about. And also for that reason, it's worth encouraging what maybe your now adult children to have their cholesterol levels checked, as that could have implications for your current and future grandchildren. For most of us, the first time we ever have our cholesterol checked is when we have an NHS health check, which is at the age of 40, and quite often that can be too late as well. So the National Institute of Health and Care Excellence, they develop national guidelines, which all us healthcare professionals have to stick to when we're managing or considering FH in children and young people. And that says, as Lisa's already mentioned, that where there's a family gene, which may have already been identified, that children of parents who are known to have FH should be offered what we call cascade testing, which is the process of testing a child for a gene which has already been found in their family. And that ideally should be done by the age of 10 or as soon as possible thereafter. And the person who can refer you for genetic testing is your GP. And the most common form of FH that we are talking about tonight is what we call heterozygous FH, so where a child inherits one mutation from one parent. But there are, as Lisa said, homozygous FH, where children can inherit a mutation from each patient or from each parent, and that is quite severe, and often that's picked up much sooner because those children start to develop clinical signs. But for most of you, and for the purpose of tonight's talk, we're talking about heterozygous FH. Now, cascade testing is the gold standard of testing for children to check for a gene which has already been identified in their family. And we do it here at Harefield by obtaining a saliva sample. And that then gets sent off to the lab, and generally it takes about 6 to 8 weeks for the results to come back. And in most cases for children, a blood test is only required if they've got a confirmed genetic diagnosis of FH, because what happens then is that we instigate our treatment plan, and we like to know what their baseline levels are and what levels we're then working towards. So, and then children who are either being investigated for FH or having their FH managed should be looked after by somebody who's actually a specialist. So somebody who knows all about FH and they're used to looking after children and treating those children and young people with high cholesterol. As we've already heard, FH is a genetic condition and children are born with it. So from the very day that they're born, their body is producing higher levels of cholesterol, and that therefore puts them at risk of early heart disease in adulthood. But the treatment for FH, as we've heard from James, is simple and it's straightforward. It's a combination of two things. It's a healthy lifestyle and it's medical management. And healthy lifestyle, I often talk about it as they're the risk factors that we can kind of manage ourselves. So what does that involve? Obviously, adapting a healthy eating behaviors is really, really important from a young age. We've got to do that with all of our children, irrespective of whether they've got FH or not. Encouraging children to eat fruit and veg, and that's not always easy, but we do hope that we don't get too hung up on the healthy eating or not fulfilling that aspect of their management, because one day, they will start to listen. It may not be until they've left home, but they will do one day, and they will take all of that information on board. We'll get there eventually. And as Lisa said, whilst it is important to eat well and have those good healthy eating behaviors, being 100% strict with your intake can quite often be counterproductive. And the reason for that, because it is hard to stick to when you're being really strict. And it's unlikely to have a profound positive effect on your cholesterol levels or your LDL levels. So for children, treats are allowed, but it's everything in moderation and about being, sensible with what they have. What's even more important is exercise and sport. If you've not got a sporty child, maybe encourage them to go out on a walk with you on the weekend, take your dog for a walk, or family walks, and for children who are sporty, finding something that they enjoy doing, whether that's rugby, football, tennis, whatever, and just enjoying that sport, really. Smoking is a no-no, so don't bow to peer pressure. And excessive alcohol intake as they get older too, because that can have different effects. It can increase your triglycerides, your blood pressure, and it can also increase your weight because of all of the calories in there. And the reason we talk about a healthy lifestyle is not because it will effectively treat and lower your cholesterol levels, but also it will avoid you developing other additional risk factors for early heart disease, such as obesity and diabetes. But one of the biggest risk factors that we can't change is our genetics. And that's what causes FH, and that's where the medical management is really important. So starting your child on medicines to lower their cholesterol, it's always going to be a joint decision between the family, the child, no decisions about them without them, and your doctor who's looking after you. And cholesterol lower medication is recommended from the age of 10. Sometimes doctors might think it's appropriate to start much sooner, maybe from the age of 8, but that's dependent on a number of different risk factors. Statins are our treatment of choice, and as James already mentioned, he's been on 10 milligrams of atorvastatin when he was first started treatment, and this is taken once a day, every day. And it's really important once your child starts taking medicines that we ensure the compliance, because once they stop or they dip in and out of their medication, their cholesterol levels tend to rise back up again. In saying that, medicine is evolved since I first started doing this job. It's changed quite a lot and dramatically, and contemporary treatments that we're now using in adults, such as PCSK9 inhibitors, they've been introduced for children, but there are strict prescribing criteria. But it does mean that we are moving forward and we're exploring different treatments for children. We've got research going on at the moment, trialing inclisiran for young people with FH as well. So that's something in the future. Inclisiran is a 6-monthly injection, so it may make the management of cholesterol levels in children and young people much easier. And as parents, we get that you're going to feel worried about passing on FH to your child, but there's no reason why your child can't fulfill a normal and healthy life just like the rest of their friends, and like James already reiterated. And I think Jamie's looking at me now, so I might have to wrap up soon. There's lots and lots of information on the Heart UK website around FH, children and young people. So do go and have a look, because it is really informative. And get in touch if there's anything that you'd like more about, because we are here to support you and your family on this FH journey. And just another plug, finally, sorry, James, we are looking for volunteers to join our Young Persons Advisory Group. So if that's something that you think your child may be interested in, then definitely get in touch with us now. But yeah, that's all I've got to say. Well, I've got loads to say, Jamie, but I won't go on. But I just put some questions in the chat and we can address them later. Thank you.
Thanks, Lorraine. That was great. And I was fortunate enough to actually pop down to Harefield a couple of weeks ago to see Lorraine and the clinic in action. And yeah, it really is a credit to you and your colleagues to see how you you manage the patients and the families. So as Lorraine rightly says, anyone that has an interest or feels they can support in any way, please do get in touch. So we've heard a little bit about kind of pathways of care, about genetic testing, both for individuals and their families. But what should you expect in relation to this, and how can you use sort of knowledge and awareness in this area to help you access services? So to talk to us now about kind of optimum care in relation to lipid management is Dr. Pete Green, who you've already heard from at the start of this webinar. So as well as being Heart UK's current chair, Pete has also been a GP in Medway, North Kent for over 30 years. As clinical lead for Medway Clinical Commissioning Group, Pete ran a pilot demonstrating the systematic identification of patients at risk of FH, and in that confirming a clinical diagnosis from the information already held in GP patient records, and thus influencing actual nice guidance in supporting systematic identification. So over to you, Pete, to talk to us about kind of optimum care and you know, what you can expect.
So thank you very much, Jamie. So what I'm going to sort of cover is what are we trying to do, which numbers are important, because that can be quite confusing, and the way as clinicians we think about the problem. Now, one of the important things, I'm a GP and I know different people have had different experiences with their GPs. Some GPs are very informed, other GPs seem to be less informed. The GP's role is to know something about everything. That's a big job, to know something about everything. And in a simple sense, a consultant's job is to know everything about something. So they've got a much smaller range of things they need to know about, but they know everything about it. And to be fair to some of our other presenters, the nurses, the dietitians, and the allied health professionals, they often know even more about a subject than we do some of the time. But the other important person is yourself as a patient. It's really important to be informed, to understand what you should be looking to try and achieve and how that can be done. And I'll be sharing some of that with you, and I'll also be sharing some of the advice and guidance that we use in primary care and secondary care to do this. So what are we fundamentally trying to do? Well, we're trying to treat lipid levels because we know there is a link between particularly low density lipids and the furring up of blood vessels. Basically, if you've got too much limescale in your hot water system at home, it furs up your kettle. It doesn't work as well. If we fur up the blood vessels in the body, that causes them to narrow, and that causes them to affect the blood supply to your heart, your brain, your kidneys, your legs, and that's what causes the conditions that we're trying to avoid. So the heart disease, strokes, vascular dementia, peripheral vascular disease. So that's what we're trying to prevent. And the good news is that we know that for most people, lipids is very treatable. So we know that for most people, if you have a raised cholesterol, it is very treatable. And statins are not the only medication that we have available to us. So there's the whole lot of lifestyle things as well, and then there's the medications. Some of the lifestyle things may of themselves not necessarily reduce your lipid levels, but you've got to remember, what are we trying to do? We're trying to prevent people have atherosclerotic, so that's furring up of the blood vessels, cardiovascular disease, disease that affects your heart and your vascular system, your brain and your limbs. And there are other things that affect that, as we've heard, so exercise, smoking, diet, blood pressure, diabetes. So it's important that when you're trying to look after yourself, that you're looking after all of your risk factors, which includes your lipids, and not just your lipids in that. And often the things that are good for advice for lifestyle are good for many of those things. And as we've heard before, it is the duration. So it's not just the level, it's the duration that the level's been raised for. So we find with many conditions, such as say blood pressure, that tends to go up as people get older. Equally with diabetes, particularly with what they call type 2 diabetes, the type of diabetes that develops as people get older, linked with obesity, it tends to become more common as people get older. And again, when we're looking at the lipids, there are that group of patients with familial hypercholesterolemia who have those raised lipids from birth. Hence, it's very important we're treating people from early as possible. There are other people who develop higher lipid levels as they get older, and it's important that we pick those people up and we treat them from there. So equally, when we talk about risk, so there are people with normal lipid levels who don't smoke, who have a normal weight, who run marathons, who still have heart disease. We may not know necessarily why they've got heart disease, but we know it can still happen. So we can't necessarily prevent something completely, but what we can say is that if we can lower your lipid levels, we can improve your lifestyle, we can decrease your risk of something happening. We can't say it will never happen. And of course, some of the things we're trying to prevent can be quite catastrophic. You know, if you have a major heart attack or a major stroke, that can be catastrophic to your life. It can even be life-threatening in that sense. So we're trying to prevent the atherosclerotic furring up of the blood vessels affecting primarily cardiac disease and brain disease. So we need to look at it in the round for that. So what number's important? Okay, and this is another question, because you'll all have heard of sort of total cholesterol, low density lipid cholesterol, high density lipid cholesterol, non-high density lipid cholesterol. And it can all get quite confusing as to which one is important and which one is the more important to people. Now, most of the research has been done on looking at low density lipids, and these seem to be particularly bad in terms of causing furring up of the blood vessels. The difficulty is when we start measuring things in the laboratory, we don't measure low density lipid, we calculate it from the other blood fats that we look at when we do the testing. And we also know that the low density lipids can be affected by whether you're a fasting patient or a non-fasting patient. And many of you will remember that probably up till about sort of 5 or 6 years ago, we were quite insistent that people fasted to have a blood test. These days, we're less worried about that. We can do it on a non-fasting sample, which adds a great deal of convenience to patients, makes it a lot easier to get the blood test done. But because of that, we're tending to move to a thing called non-HDL cholesterol. And by sort of definition, if it isn't HDL cholesterol, it's LDL cholesterol. So it's a funny way of saying it's LDL, but it isn't quite the same thing. But the reason we're moving towards talking about non-HDL cholesterol is because it is less affected by whether you fast or not. And that makes it easier in terms of doing the testing for that. So some of you will still hear different people talk about different levels, but you need to be an expert patient. You need to understand what levels are important for you and which of those levels are important for you, and ask specifically your clinician, your consultant or your GP what that is and what their target is. Now, if you Google, you can look up Lipid Management Guidelines 2022. And if you Google that, you will find a 2-side piece of A4 designed for doctors and healthcare professionals looking after people with raised lipid levels. Yes, it's for medics, it's a bit complicated, but all the information there is also available in patient-friendly formats on the Heart UK website. Okay, but that's the bit that the doctors and the clinicians and the nurses will be looking at. And if they're not looking at that, show them a copy of it, sort of thing. And primarily when we're looking at this, we're looking at 3 groups of patients. So we're looking at what we call secondary prevention. So these are people who've already had a heart attack or a stroke or heart disease from furring up of the blood vessels. So we know they've got a problem. We're then looking at the people with FH who we know they've got raised lipid levels from birth. So they're a particular group of patients we need to identify early and manage well. And then we're looking at everybody else. And what we're doing with everybody else is to say, well, what do we think your risk is of getting heart disease, particularly over the next 10 years? And the rule of thumb in that is that if it's more than 1 in 10, so if it's more than 10%, probably we should be doing something to try and reduce that risk. And that doesn't seem sort of unreasonable. But these are conversations that clinicians will be having with you as a patient, with your family, with your relative, because each of us will make our own choices in life. And it's not for the clinicians to tell you what you should or shouldn't do, but it is for you to be able to have it explained in a way you can understand the risks or benefits of whatever course of action you choose to take, whether it's diet, lifestyle, medication. Now, for people who've got secondary prevention, so these are people who've already had a heart attack or had an event or something like that, we have quite tight targets. And we've already mentioned what we call the National Institute of Clinical Excellence. And this is a body within the UK that sets guidance for clinicians in terms of how best to manage patients, what levels they should be looking at, what therapies they should be looking at, and what order they should be looking at providing those therapies in. And there will be slight differences between the numbers that maybe NICE use and some of the numbers that the American societies use and the European societies, but they're all broadly fairly similar. And you may, because of your particular circumstances, have a number that's even lower than some of the numbers suggested, because that's what your consultant has recommended for you as an individual. And within that, so for secondary prevention, we're looking at to try and get what they call non-HDL cholesterol levels below 2.5. For some patients, it will be even lower. Now, how are we going to do that? So clearly lifestyle plays an important part in that, but to get to those levels, the majority of patients will need some form of medication. Statins form the mainstay of that medication. We know that about 9% of the population, for various reasons, are intolerant to statins. Statin intolerance is a real thing, but it's nowhere near as high as it's estimated and you would read about in the newspapers. Equally, there are some people who will not tolerate one statin, but are perfectly okay on a different statin. And there are some people who are okay on a certain dosage, but can't tolerate a higher dosage. So it's always useful to think, should I try a different statin? Should I try a lower dose? But on top of the statins, or instead of the statins, there are other medications available to us. Ezetimibe, bempedoic acid, and then some of the newer injectable medications, which again can help lower cholesterol. So your risk is related to your lipid level, and the important thing is to get that lipid level as low as we can. That decreases your risk of having future events. In FH, we know the treatment is the same pretty much. The important thing is to find people as early as possible and to start the treatment, because we want to prevent them having a problem. We want to prevent you becoming unwell from it. Raised lipid levels is not an illness. It's a risk factor of becoming unwell. People with high cholesterol do not walk around feeling unwell until they get damage from that raised cholesterol. It's the damage that causes the problem. So if we can keep the lipid levels down, their risk is no more than the next person. And as James talks about, that's the most important thing to keep people healthy. We've then got that group that we call primary prevention. So these are the people that we know may be at risk of developing heart disease, and heart disease becomes commoner as we all get older. Hopefully we all do get older, but we know that becomes commoner. And one of the things that your doctor may look at is a thing called Q-risk. So Q-risk calculates the risk of you developing cardiovascular disease or heart disease over the next 10 years. And it takes into consideration your age, your sex, your ethnicity, deprivation, smoking, diabetes, family history, blood pressure, kidney disease, arthritis, your BMI, and your cholesterol levels in it. So it takes in a wide range of factors that do that. If the risk is above 10%, it's generally suggested that your doctor or one of the nurses has a conversation with you about how that risk could be reduced. Equally, we know that in patients who have diabetes or have kidney disease, they may be at higher risk as well, and those conversations occur there. And again, the starting point is generally statins, but as we know, some people are intolerant. There are other medications available, and there are other statins available. So it's not, I don't like statins, I shouldn't take anything. The risk is around your cholesterol level. So there are other medications available. And if you want to reduce your risk, fine. Do all the lifestyle things, do all the diet things. If your lipids are still high, there are medications that can help from that. So that's really what I sort of wanted to say from there. But become an expert patient, become an expert in your own understanding of where you should be, what's important to you, and equally discuss that with family and friends so they're informed as well. Not all GPs will know all the details. Use that lipid management guidance, share it with them. If they haven't seen it, share it with them. They're going to say thank you. They're not going to push back on you. So I will hand back to Jamie at that point.
Pete, thank you very much. That was a really informative talk, and hopefully lots to take away there in terms of advice. And ultimately, knowledge is power, and becoming that expert patient can only help in your own healthcare management. So thank you. So for many conditions relating to high cholesterol and blood lipids, and as we've heard about today, effective management will require some medical treatment or medication. And the development of new treatments, medicines is an area clearly of vital importance. And we've seen that none more so than during the COVID pandemic. So here to talk to us today about developments in treatment, particularly in relation to lipid management, is Professor Dev Datta. Dev is a consultant in metabolic medicine, is the clinical lead for the lipoprotein apheresis service in Cardiff, and is also medical lead for the Welsh FH Cascade testing service. Professor Datta runs a clinical nutrition service addressing medical complications of eating disorders, and is also clinical lead for the specialist weight management service in Cardiff. Dev is also a trustee of Heart UK, and is course director for the Masters in Preventative Cardiovascular Medicine at the University of South Wales. Dev, over to you.
That's great. Thanks very much, Jamie. Thanks for the opportunity to speak to the audience this evening. I think one of the things I'd say before we start talking about new developments is newer doesn't always necessarily mean better. And that's the same is true within medicine or within many things in life, I guess. And it's worth remembering that although we do have newer therapies in the pipeline, which I'm going to touch on presently, it's worth knowing that a lot of the treatments that we have are very effective. And one of the things about well-established treatments is that your doctor, your clinical nurse specialist, your pharmacist, anyone who's involved in your care will have a lot of experience, and the global experience of well-established treatments is particularly good around a lot of the lipid lowering therapies that we use. And so even though people may have concerns about using statins, one of the advantages of using statins is that as a health community, we have an enormous amount of experience with them. That having been said, there is undoubtedly a space for newer therapies to develop. I'm going to touch on some of the things that have sort of become available over the last few years, and then we'll move on to onto the future in a moment. Of course, when we think about research and development in medicine, we do tend to focus on technological advances and medication advances. But it's important to recognize as well that we continue to develop our understanding about non-pharmacological developments in medicine and related to lipids. And that, of course, means diet and lifestyle. So we shouldn't forget the importance of those factors when we're thinking around developments. And indeed, research continues unabated in those areas. Sometimes there's a lot more controversy when we read about research related to diet and lifestyle. And that's because when we carry out research related to diet, for example, it's a lot harder to compare groups. And when we do research, we look at a group of people who are on, we'll call it treatment A, and then a group of people who are taking, if you like, a dummy pill, what we call a placebo. That's harder to do with diet. So the way in which we carry out research for dietary development is different. However, it doesn't mean to say that our understanding doesn't continue to improve. And of course, an excellent resource for new developments related to diet is the Heart UK resources, which I'm sure you're all familiar with. And that's certainly where I direct all of my patients to, in the absence of my service, unfortunately having lots of things available to me, but not having an expert dietitian allied to my lipid service at least. So that's just a little bit of background before we launch into the new and exciting. Dr. Pete Green sort of alluded to some of the newer therapies that have become available, and I'll just touch on them now. So I'm sure most of you are familiar with statins and also another drug which we often use, which is called ezetimibe, which we'll often use in combination with a statin and occasionally on its own. We do have a newer tablet medicine which in general is used as an alternative to statins, something called bempedoic acid, and that's available for use throughout the UK. It works in a slightly different way to statins, but if we were to look under the microscope at the bit of our body, the bit of our cells where this new drug bempedoic acid, or relatively new drug bempedoic acid, is working, it's working in a similar bit of the body where statins work. However, it seems to preferentially work within the liver rather than muscles. So we've had some quite good experiences with our patients who've had muscle-related problems with statins, is that bempedoic acid is an alternative. It's available as a combination with ezetimibe, and when we use it in combination with ezetimibe, the effect is not quite as good as with a statin, but we can see some reasonable responses to it, and we've had some successes with it. One of the things to bear in mind with that, and also with a few other newer medicines, is what we call, and I explain this to all of my patients, is what we call outcome evidence. What do we mean by that? And that's what we mean by that is where we have a newer medicine in lipids, when we have it available for our use in the NHS, it's sometimes available for our use where we've demonstrated that it reduces cholesterol, LDL cholesterol in particular, and it does so very effectively. And we believe that that's going to be translated into reduction in heart attack and stroke and vascular disease. Now, we've shown that categorically for a number of different medicines, which are well established, but we have not yet shown it for bempedoic acid. So we know that bempedoic acid reduces cholesterol, can be quite effective, but we've yet to show that it stops heart attacks and strokes. Now, the inference we would anticipate that it probably should do that, and that will be the source of ongoing research, and that research will become available over the coming years. A similar story for inclisiran. Lorraine mentioned it earlier. So this is the twice yearly injection, which many of you will have come across. We know that it's very effective, but we're yet to show that it reduces heart attack and stroke. And we suspect that it probably does, but we're yet to definitively show it. The other group of drugs similar to inclisiran, again, an injectable drug, and these are what we call the PCSK9 monoclonal antibodies. We used to call them PCSK9 inhibitors, but that's perhaps not precise enough language. But these are self-administered injections which come in a pen device, which you administer once every fortnight. And those drugs have been shown, as well as reducing LDL cholesterol very effectively, to reduce heart attack and stroke as well. So those do have what we call outcome evidence already. Another drug, not an LDL lowering drug, something called icosapent ethyl, is a drug which we're starting to use for people who've got higher triglycerides and also have evidence of cardiovascular disease. And so that's sort of a snapshot of some of the newer things that have come to us as to be available to prescribe over the last couple of years. What about the future? And I'll do a little bit of a description of where I perhaps see the future might lie over the next, by future I mean over the next 5 years rather than the next 20. And so I think perhaps one of the most exciting areas which we will touch on within this webinar is around lipoprotein a. If you're not familiar with lipoprotein a, there's some excellent resources on the Heart UK website which give you some easier to understand information about lipoprotein a than is available out there. So if you Google it, you'll find lots and lots of information out there, some of which can be quite difficult to understand. But if you look it up, it says capital L, small p, open brackets, A, close brackets, and we just call it lipoprotein a or Lp(a). Now, we've known about Lp(a) being important in causing vascular disease for some time, and we're going to hear about this shortly. But developing new treatments to address Lp(a) is an exciting new venture, which we will have some answers around over the next few years, as in the next 5 years. So we hope to have treatments available for hyperproliferative within the near future. Does that mean, and I saw this as a question that was submitted earlier, that people have got high Lp(a) are in a spot of bother now? Not necessarily. We believe that modifying things that we can modify does effectively reduce the risks associated with Lp(a). So it's definitely not all bad news, but we think that there is significant opportunities over the next few years with respect to research around Lp(a) in particular. And I'll talk a little bit about clinical trials in a moment, but you may well be asked, if you've got high Lp(a) and you also have had heart disease, you may be invited to be part of research, or you may have already been asked, but you may be asked over the coming months about whether or not you'll be interested to contribute to research. And I'll touch on why that might be something that it's worth thinking about and giving due consideration to in a moment. Are there other new areas of development in this area? For sure, there's quite a few, and I'm not going to bore you to tears with all of them, but there are a few, and I've just touched on one of them today. So to close off, I've just got another couple of minutes. Research. I've just given you a snapshot of what research actually is, and how we kind of carry it out, particularly around drugs. But you may well be invited by your lipid clinic, by your cardiologist, and increasingly by your GP. So lots of us are involved in research, and you may also be invited by a third party. There are companies out there who work with the NHS who might invite you to contribute to a research study. Why do this? And I think there's been a lot more interest around people being involved in research since COVID, and I think COVID is a good example of how it put to the forefront in our thinking the benefits or potential benefits of research and what they actually meant, because we tangibly saw the benefits fairly quickly. Might not felt quickly, but a year is very, very, very quick in medicine, and most of the stuff that we do in terms of developing new medicines do take us a number of years. Why contribute? Well, opportunities. I think as a person living with a condition, it's an opportunity to be involved in something new. It's an opportunity to have access to a new therapy. Although bearing in mind that if you're involved in in most of our drug development studies, this may well be a placebo that you're offered, and you don't know if it's a placebo, a dummy drug, or the active drug. So it's worth just bearing that in mind. Is it safe to be involved in research? Yes, there's lots and lots of safety considerations which we consider, which as researchers we have to pay attention to, and so if it's being run through an NHS entity, you can be comfortable that anybody who's involved in research, their safety is absolutely paramount. That's the most important thing that we are obliged to think about when we think about research. So worth thinking about, and if you're invited to maybe have a chat with the clinician who's invited you to that. Thanks very much. Thanks, Jamie.
Yeah, thank you very much. Again, another really insightful talk, and it's always really interesting to hear about what's in the pipeline in relation to treatments. So thank you for your time. We've talked a lot about cholesterol this evening, and although that is the most common and well-known blood fat, it is only one of a number of lipids circulating in our blood. So here now to give us an overview of other blood lipids is Dr. Dermot Neely. As former head of the lipid clinic at the Royal Victoria Infirmary in Newcastle, Dermot was an expert advisor on the NICE lipid modification guidelines and a member of the guideline development group for the CG 181 guideline. He's now retired from clinical practice, but is currently a specialist advisor on lipids to the Academic Health Sciences Network for the North East and North Cumbria. And he does sit on the NHS England Special Advisory Group on FH. Dr. Neely is a founder trustee of Heart UK, and he also co-chairs the Heart UK FH Intelligence Network. So Dermot, over to you.
Thanks, Jamie, for that very nice, kind introduction. So we've heard a lot already about LDL cholesterol, which is the main form of bad cholesterol in the blood, the one that is raised in most people with high blood cholesterol, the one that is doubled in people with FH, and which is successfully reduced by treatments such as statins and other lipid-lowering drugs such as ezetimibe, which speed up the removal via the liver LDL receptors. But there are other forms, as Jamie mentioned, of bad cholesterol in the blood, and I just want to briefly talk about these. Now, firstly, triglyceride. So triglyceride is an important blood fat, and together with cholesterol, deliveries of blood fats are very important to maintain our health. At meal times, triglyceride or ordinary fat is taken from the food, absorbed by the gut, and then packaged in large globules. If you think of LDL as a tennis ball, this is going to be a beach ball, very big, and that will deliver the ordinary fat to our muscles and to our storage areas, the adipose tissue areas. And once that delivery has been completed, the globule or ball shrinks down to a much smaller size, which we call a remnant. Now, that remnant contains cholesterol and triglycerides, and in some cases, people are slow to remove those remnants from the blood. And like LDL, they can stick to the artery lining and cause furring up in the long term. So remnants are potentially as damaging, maybe even more so than LDL. But thankfully, it's only a small minority of people who have a problem with removing and converting remnants into safer forms. Between meals, the fat that's been stored elsewhere in the body is sent back to the liver, where it's repackaged, and together with cholesterol enters the blood in a bigger globule about the size of a football, bigger than the tennis ball, but not as big as the beach ball that we came from the gut. Now, this is called VLDL, and it delivers ordinary fat, again, to our muscles and storage areas, and then it's converted into a small IDL remnant, which is a bit like the one we mentioned coming from the gut. And finally, that is then changed into LDL. Now, once again, some people are slow to deliver the triglyceride or ordinary fat to the muscles and storage areas. And in some cases, the body is producing more ordinary fat than normal, perhaps because of a high sugar intake or a high alcohol intake, or because the storage areas are full because of overweight. But any of these can be reasons for the triglycerides to be increased. And that will slow down the efficient delivery of cholesterol via LDL. So we recognize that in some cases, high cholesterol in the bad or non-HDL fraction is accompanied by high triglycerides, and this may need a fasting sample to sort it out. Now, on a fasting sample, the gut should not be contributing to triglyceride in the blood, so the chylomicrons from the gut should be absent. If they're still present on a fasting sample, it could be that there is a problem with the initial processing of fat in the chylomicron coming from the gut. And that can have serious consequences. It may, in fact, cause pancreatitis if the triglycerides get extremely high. But once again, this is something that may need further investigation if the initial non-fasting blood test shows the triglycerides are too high. So just moving on from now, LDL is a bit like a tennis ball. It's normally one which is removed easily by the liver, by the LDL receptor. But in some people, an additional protein gets stuck onto the surface of this tennis ball, and this is called the ApoA protein. Now, I often talk about this as a piece of Velcro, which is two major consequences. Firstly, it makes it stickier. So the LDL-like lipoprotein A particle is more likely to get stuck on the blood vessel lining. And secondly, it interferes with its efficient removal via the liver LDL receptors. So statins don't really help to reduce LPA very effectively. So for that reason, treatment of people with high LPA is mainly focused on reducing other risk factors and managing as best we can the non-HDL cholesterol through the usual statins, ezetimibe, etc. As Dev has just mentioned, treatments are currently in development to try to prevent people from producing this extra piece of Velcro. And new treatments we expect may come in future if the trials are successful. But for now, the main focus is to reduce the other risk factors. Now, it's very important to recognize that in people with high triglycerides, it's a combination of a variety of important diet and lifestyle measures that can actually be used for the initial management of high triglycerides. So we know that reducing weight can help, reducing sugar intake can help, reducing alcohol intake can help. But in some people, there may again be a genetic problem with the initial removal of ordinary fat from the big chylomicron particles. And this is called lipoprotein lipase deficiency or familial chylomicronemia syndrome. And this is an important diagnosis to make because it can actually cause very high triglyceride in families and can result in early pancreatitis. There's another condition which I should mention called familial combined hyperlipidemia, which looks very like familial hypercholesterolemia, but there are higher levels of triglycerides. The LDL is often lower, but there's usually a higher level of remnants in the blood. And although the genetic cause of this has not been well established, it is very effective to apply the usual treatments, statins and ezetimibe, and bring this under control. In people with highest triglycerides, there may be a need for other treatments such as fibrates, and there are some new injectable treatments for the people that are most severely affected. So there are treatments for all these conditions, but broadly speaking, initial diet and lifestyle measures are really important in anybody who's told that their triglycerides are high. So I'm not too sure whether we've got much time left, Jamie, but I think that's all I really have to say about the other conditions.
That's great, Dermot. Thank you very much. And apologies to anyone that may have lost Dermot on a couple of occasions during that speech. We definitely got the gist of it. But I think it's safe to say that internet connectivity in Barcelona maybe isn't as good as it is over here.
If there's any bits that we're missing, I'd be happy to answer clarify any individual bits of it.
Great. As far as I was concerned, Dermot, we got the vast majority. There were just a couple of occasions where you just dropped out a little bit, but no, that was fine. Thank you. So I think as we've heard in lots of the sessions tonight, high levels of cholesterol and blood lipids in our systems can be caused by factors beyond our control. But there are things that we can do to reduce our levels. So with information and advice on what we can do to make a change, is our final speaker of the evening, Lynne Garton. Lynne is a registered dietitian with over 30 years experience, and has been Heart UK's dietetic advisor since 2019. Here she works on all Heart UK's diet and nutrition related matters, and many of you may have had some advice from her through our helpline. Her philosophy is to provide nutritional advice that is based on sound science, yet is practical and realistic for today's way of life. Lynne, over to you for our final presentation of the evening.
Thank you, Jamie. And I'm delighted to be talking tonight. So thank you for inviting me. Now, often I get asked, how important is diet in managing the risk of heart disease? And the simple answer is very important. And I'm delighted that this has already been highlighted by the previous speakers. Poor diet is one of the leading modifiable, and by modifiable I mean things that we can do something about, risk factors for heart disease. But as Dr. Pete Green has already mentioned, diet also impacts other modifiable risk factors such as obesity, high blood pressure, type 2 diabetes. So a healthy diet is essential to managing risk. But what is a healthy diet? Well, dietary patterns that are low in saturated fats and added sugars and contain good amounts of healthier fats, fiber, whole grains, fruits, vegetables, and other plant foods have been associated with better heart health outcomes. Now, there are a number of ways this can be achieved, and various dietary patterns which have been proven to be beneficial include the Mediterranean type diet and even our own public health dietary recommendations. And as an aside, we can often hear in social media circles and by certain people that our dietary recommendations are all wrong and this is the reason for the nation's ill health. But when we actually look at how many people are following all these recommendations, it's tiny. Less than 1% of the population are meeting all the dietary recommendations. So it's not that our healthy eating recommendations are wrong, it's that no one's actually following them. So as there's no one diet fits all, how can we put these dietary principles into practice? Well, I've put together some sort of like top tips. The first one, which we've heard about, is maintaining a healthy weight. The second one, which has already been alluded to, is cutting down on saturated fats and replacing these with unsaturated fats. Now, saturated fats are found in full-fat dairy products, fatty meats, processed meats, butter, lard, ghee, coconut oil, pastries, cakes, and so on. Whereas unsaturated fats are found in things like oil, such as olive oil, sunflower oil, rapeseed oil, and spreads made from those, as well as nuts, seeds, and oily fish. Now, a common misconception is that, well, if we're recommending these healthy fats, then we can eat as many of them as we want, eat as much oil, as much spread, and that's not the case. When we look at the dietary recommendations, the fats and oils only form a very small part of the diet. So we still need to watch these and still need to have them in moderation. Particularly is because all fats, whether saturated or unsaturated, are a concentrated source of calories, which can ultimately result in weight gain if we're eating too many calories. Next one is to choose whole grain foods instead of the refined starchy foods. So these are things like wholemeal bread instead of white bread, wholemeal pasta instead of white pasta, brown rice, whole grain breakfast cereals instead of sugary cereals, and especially things like oats, which are a fantastic breakfast cereal. To eat plenty of fruit and vegetables, choosing a wide variety, different colours, and it doesn't have to be fresh. So frozen, tinned, say tinned fruit in natural juice, and dried fruit also all count. And to choose healthy sources of protein, so things like low-fat dairy foods instead of full-fat, beans, lentils, nuts, peas, poultry, so chicken with the skin removed, and fish. And if red meat is eaten, to choose the lean meat and also to watch the quantities. Aim to have 2 portions of fish a week, one of which should be oily, so salmon, mackerel, sardines, pilchards. And to eat fewer processed foods and drinks which are high in sugar and fats and salt. So these can be things like biscuits, cakes, chocolates, pastries, fizzy drinks, sugary drinks. To limit high-fat takeaway foods and ready-prepared meals. And if you do choose a ready-prepared meal, choose one which is lower in saturated fat, and looking at the nutritional label, looking for the green on the colour coding, and cooked from scratch more often, because then you know exactly what's going into the food. And if alcohol is drunk, then to drink within sensible limits of no more than 14 units a week. Now, we have a lot of information on all of these aspects on the website, which I'd urge you to go onto the website. And we've also got a diet checklist, which you can use to assess the quality of your diet and see how that compares to these dietary principles of a heart healthy diet. But when it comes to managing cholesterol specifically, these dietary principles still apply and they can lower cholesterol. And this does form the foundation of a cholesterol lowering diet. But there are other foods that can be included on top of this, which can have further cholesterol lowering benefits. And these have been investigated as part of what's called the portfolio diet. And these added foods include nuts, oats, soya, and foods fortified with plant stanols and sterols. And the portfolio diet studies have found that when these foods are added to this heart healthy foundation diet, they have further cholesterol lowering benefits above and beyond the healthy foundations. And we've actually adapted the portfolio diet to be a more practical and sort of realistic diet in our ultimate cholesterol lowering plan, which you can find on our diet. But when it comes to diet, there is a lot of confusion out there, and specifically around cholesterol management. And that tends to be because the focus gets placed on individual nutrients, such as saturated fat. But we don't eat nutrients, we eat foods. And then we don't eat foods in isolation or in a vacuum. We eat them as dietary patterns. So this is why the area of research is really now focusing on achieving a healthy dietary pattern. We know the nutrient that has the biggest effect on cholesterol is saturated fat. Diets high in saturated fat increase cholesterol, and swap into unsaturated fats can lower cholesterol. And this comes from a wealth of evidence that dates back 50 or 60 years, and the evidence for it is only getting stronger. But again, on social media, and certain people would like you to think otherwise, saying things like saturated fat doesn't matter, it's the carbs or it's the sugar. But these people are also often believe that actually cholesterol isn't a problem in reducing heart disease. So if they believe this, then of course saturated fat doesn't matter, because saturated fat's action is through cholesterol. And on the topic of low carb diets, because this was something that was highlighted in some of the questions, these have become popular as a weight loss tool, specifically with people who have type 2 diabetes. But the research, when they compare low carb diets with other types of diets, there doesn't seem to be any superiority in weight loss. And also, when you look at cutting out foods, cutting out carbs, which can also contain important nutrients such as fiber and whole grains, and we know these are beneficial for heart health. Now, I mean, fiber particularly is particularly important because currently the fiber in our diets is shockingly low, and only around 17% of the population are meeting the 30 grams a day recommendation. And also, it's what replaces the carbs that can result in the problem. A number of low carb diets promote foods high in saturated fat as a replacement, and then of course when you have a diet high in saturated fat, it increases LDL cholesterol. A number of questions were also asked about how much can diet reduce cholesterol, and that's a really difficult one to answer as it is very individual. And it also depends on a number of factors, such as what the baseline cholesterol levels were to start with, what the diet was like to start with, the number of changes that have been made and also maintained, and any other health conditions, as well as individual variations to diets. But as we've already highlighted, and as Dr. Green has already highlighted, this diet's not just about managing cholesterol, it's also for other heart disease risk factors. But if we look at the studies investigating dietary interventions to reduce LDL cholesterol, they're suggesting diet can impact cholesterol by about 10 to 20%. And the portfolio study, which is when there was strict compliance, actually resulted in an LDL cholesterol level of about 20 to 30%. And finally, the only other lifestyle aspect to consider is exercise. While exercise can have a small impact in reducing LDL cholesterol, it can have a big impact on reducing triglycerides, raising your HDL, helping you to stay a healthy weight, and helping to lose fat from around the middle. And it can also help lower blood pressure and lower the risk of type 2 diabetes. So really important for heart health. And the recommendations are to do at least 150 minutes of moderate intensity exercise, which is where your heart is beating faster, you're slightly out of breath, but you can still talk. And if you're not used to exercise, you should always build up, start slowly and build up. Now, I appreciate that this really is a very quick overview of the lifestyle aspects and that impact cholesterol and overall heart health, but I hope it was useful. Thank you.
Lynn, that was great. Thank you very much. As someone who has undertaken the diet checklist questionnaire myself with Lynn's help, then you know, I can testify to its you know, to its use and its benefits. And you know, within you know, I said undertaking that, I've personally changed my own diet to incorporate more heart healthy foods. So thank you, Lynn, for that. That's it for our presentations, but not for the webinar. We now would like to open things out to you. We've got a fantastic panel of experts, as you've all heard from this evening. So now is your opportunity to ask them any questions that you may have about your own situation, one of a family member, loved one, etc. I know there's been some questions, quite a lot of questions that have come in tonight, and some that have been submitted during the registration process. So I'd like to hand over to our very own lipid nurse specialist, Tina Dawson. Many of you, again, any of you who have engaged with our helpline will already have had some interaction with Tina, because Tina manages all the inquiries that come in via our helpline. So Tina's experience goes well beyond the 10 years that she's worked for the charity as a specialist nurse. So Tina, have we had any questions that have come in that we'd like to ask the panel?
Yes, as you say, we've had loads of questions prior to the webinar, and we've had a few come in as the webinar's been progressing. So the first one I'm going to ask is, we have a question about following a heart attack, should we be checking LDL or a full lipid profile, or just non-HDL? The query being, would we miss FH if we're not checking LDL? Which of the panel would like to answer that one? Any volunteers? Should I pick somebody?
Pick a victim, Tina.
Dermot, I'll pick you. I'll start with you.
Could you repeat the question? Sorry, I didn't quite catch it.
Yeah, we had a question about, so following a heart attack, should we be checking LDL cholesterol or just non-HDL? The main question, would we miss FH if we're not checking LDL?
No, you should check non-HDL because it doesn't require fasting. However, if there's a high triglyceride and a non-fasting test, then a fasting test could be arranged at some point to see if the pattern matches FH. Recognizing that if you have a heart attack, you're going to be placed immediately on treatment, which is actually going to affect the profile and is going to make it slightly more difficult to make a clear diagnosis. Often we'll be looking at previous measurements if they've been made, but a specialist may need to be involved in trying to sort out what the precise diagnosis might be if you're already on treatment before the first blood test gets done. But if non-HDL is well controlled, that is going to be sufficient to decide whether your treatment is adequate. A fasting test for LDL is not required for that, except if we're considering some of the newer injectable treatments, or indeed, as we mentioned, trying to make a diagnosis of FH.
Great, thanks very much, Dermot. Next question, someone's asking about, does our body need non-HDL, or would it be desirable to get non-HDL levels to 0? Who'd like to answer that one? Pete?
So lipids are important. The body needs lipids and the various different sorts of lipids. They help in metabolism, they help in cell membranes and that. So we wouldn't be aiming for 0 in that. I can't give you an absolute level which would be sort of perfect, but it wouldn't be 0.
Great, thank you.
Just like to chip in there just to say that the measured level of non-HDL and LDL generally is reflecting the efficiency of the removal system. So the more efficient the removal system, the lower the levels will be. There will always be deliveries occurring in that system. It's dynamic. If there is very low traffic levels on the road, it doesn't mean your Amazon delivery is going to be delayed or fail to occur.
Great, thank you. Any more comments? No, right, we'll move on to the next question. There's a question about lipoprotein little a. Is lipoprotein little a linked to FH, or is it something completely separate? Who would like to answer that one?
Completely separate.
Yeah, I'm happy to answer that. It's a separate gene, and the levels in the blood of LPA are determined by the LPA gene. So variation in that gene is the main reason for a high or a low LPA. We do recognize that if you've also got FH, it may actually aggravate the situation, and the LPA might be higher than in somebody with the same LPA gene but no FH. But it's a separate gene, and the LPA level is due to the LPA gene.
Great, thank you, Dermot. Thank you, Pete. I have a question about, is it worth taking Benical products? Lynn, can I ask you that one?
Well, as I said in the presentation or in the talk, that actually, that we've got to get the heart healthy foundations right. You need to get the baseline right. Now, once that's been achieved, these products have been proven to lower cholesterol if taken in the right amounts and quantities, between 1.5 to 3 grams a day. And the evidence for this and these products have been reviewed by the European Food Safety Authority to allow manufacturers to make this claim, because the science is there for them. But I would say, if cost is an issue, or if you don't like the products, or they're not essential, the most important thing is to get the kind of like the baseline diet right first of all. And then there's other cholesterol lowering foods. Oats have been shown to have a cholesterol lowering effect. Nuts have been shown to have a cholesterol lowering effect. So there's other foods that can be also included. But if you want to include them, there is the evidence there to show that they can reduce LDL cholesterol by about 7 to 12%, taking them in the right amounts.
Great, thank you very much. Got a question. How often should we have a blood test to determine our cholesterol level? Who would like to answer that one? Lorraine? Because I can see you.
Oh, that's all right. I mean, when we're looking at how often, it depends in what context. If you're taking lipid lowering therapy and your last levels were stable on treatment, then you should only have your cholesterol levels checked every year. If you've just started taking lipid lowering therapy, or you've had your medication doses changed, then we would recommend that you have your cholesterol checked about 4 months afterwards to see if that either that initiation or your change in medication has managed to get the desired effect and bring your lipid levels down, or whether you need further dose adjustment of your medication.
Great, thank you. Any other comments from anybody? Okay, next question. Does menopause have an impact on our cholesterol levels?
Yes, absolutely. Sorry, I'm having some problems with my video. For some reason, it just does not want to turn on. So it's Lisa speaking here. But yes, lipid levels do generally go up after menopause.
Great, thank you. Anyone else?
Lisa, could you just expand upon that in terms of during menopause levels go up? Are they maintained at that level post-menopause, or do they drop back down, or what's the situation with that?
So Pete or Dermot may be able to flesh out a bit more, but from what I know, once they go up, I don't think they generally tend to come down, unless obviously there's a lot of lifestyle and diet changes that are made that affect that level. But I think once they rise, they tend to stay fairly high, unless there's any major changes in diet, lifestyle. I don't know if Pete wants to come in and add anything to that.
So I don't know the complicated science behind it, but in sort of simple terms, what we understand is that the female hormones tend to keep the levels lower. Once you go through the menopause, the lack of female hormones, the levels tend to raise. And this is why cardiovascular disease is less likely in premenopausal women than men of a similar age. But after the menopause, those differences tend to level out between males and females.
Great, thank you. Question, if you are on a statin and you're following a healthy diet, is it possible to reduce your cholesterol too much? Who'd like to answer that one? Dev?
As far as we know, the short answer to that is no. There's been a lot of interest around very low cholesterol being a bad thing, and that's not been borne out from the research that's being carried out in this area, because of course we can achieve very, very low concentrations of LDL cholesterol with some of our newer therapies. And indeed, this was something that was explored as part of the research development related to some of the newer therapies, where they looked at potential adverse effects related to very, very low levels of LDL cholesterol. And as far as we understand, the answer to that is no. I suppose the caveat with that is that we've only been able to, with drugs, achieve very, very low levels of LDL cholesterol within the last 5-6 years. And so what I can comfortably say is that for our patients in whom we achieve very, very low levels of LDL cholesterol, that when we've done that over the last 5-6 years with drugs that we've had available for that amount of time, that certainly appears to be safe. With respect to statins, the evidence is even more compelling, that the concentrations that we achieve with statins in terms of reduction of LDL indeed do appear to be safe. And even when people have pretty low levels of LDL when taking a statin, there do not appear to be any unfavorable outcomes. And of course, we've been following up people who've been taking statins for decades now. So yeah, the answer to that question, I think, is no concerns, really.
Great, thank you, Dev. Can damage to blood vessels be reversed? Who'd like to answer that one?
Should I keep talking? I'll take that one as well.
Thank you, Dev.
Sort of, yes. I think, again, what we tend to find is when we think about blood vessel damage and the accumulation of cholesterol and cholesterol-like substances within blood vessels, it occurs as a sort of as a process. So we start to deposit sort of softer material, if you like, initially, and then over time, by that I mean potentially decades, it sort of gets harder and harder and harder, and that eventually starts to accumulate calcium, the stuff that we have in our bones, and potentially can sort of harden and cause calcification, we call it, within blood vessels, and that process takes quite a while. And so what we've seen in some of the research studies using some high dose statins, for example, or some of the newer therapies, is that some of the softer material that's accumulated over a few years can actually start to regress. So that sort of, if you've got softer material causing some narrowing within a blood vessel, that can actually improve with very effective therapy. It's probably not true to say that if you've got blocked arteries, can you sort it all out with medicines? I think the answer to that is no. But the notion that we can improve blood vessel function and improve some of the softer, newer narrowings that can develop in people with treatment. It has been borne out with some research studies. How do we know that? Well, interesting studies using a technique called intravascular ultrasound. So that's where a specialist cardiologist will put a little probe into your heart arteries as part of a coronary angiogram and actually use ultrasound to look at blood vessel narrowing in a little bit more detail. And that's sometimes done as part of research studies to answer that very question. And so the answer is yes, to an extent. And to sort of carry on from the last question, particularly when we achieve very low concentrations of LDL cholesterol. So that's why we're particularly enthused about the notion of high people at particularly high risk achieving very low levels, or what we would previously have called very low concentrations of LDL cholesterol, because of the benefits that might be associated with it.
And Dev, if I can just pop in there as well, I think speaking to that point about sort of, worrying about driving cholesterol levels lower, I believe it's true, isn't it, that actually physiologically normal levels of LDL cholesterol are actually much less than our population levels. So when we see their drive, being sort of driven down sort of quite low, actually they are just being normalized. They're not sort of dangerously low, below what's physiologically normal.
Yeah, absolutely. I use lots of comparisons when I talk in clinic, and you could say that I'm just looking outside my window here, and I live on the same road as my children's school. And whilst vehicles might not like driving at 20 miles per hour past a school, that's faster than you really should be driving past any human being, really. Though we know that slower is better when it comes to driving, and the same is true when it comes to cholesterol. And indeed, as you've said, the concentrations of cholesterol that we need inside of cells to do the business of that cholesterol needs to do, that Pete alluded to, is actually much lower than most of us, or any of us, really achieve through standard living.
Great, thank you. Next question, what are some of the side effects of taking a statin? Anyone like to answer that one? Dr. Green?
I can do. So, I mean, the most common side effect that people will experience is muscle aches. The problem is muscle aches are actually really, really common in lots of people. And it can be difficult then to understand, are those symptoms from the statin that you started, or were they symptoms of something else? And generally what a clinician would try and do is to try and work that out. And the easiest way is stop something and start something. If those symptoms disappear when you stop the medication and then reappear when you start the medication, they probably are linked to it. If they don't, it may have been due to something else that was happening. Now, that doesn't mean that we shouldn't necessarily be looking into why you've got aches and pains or discomfort, but it does mean that it may not be the right thing to do to stop the statin in that case for it. There's quite good guidance on how clinicians should consider statin intolerance in patients. As I said, it is real. It's not something that people make up at all. It's just not as common as people expect it to be and anticipate it is. And as I mentioned earlier, changing statin or reducing the dose can often remove those symptoms from people.
Sorry, thank you. I'm just keeping an eye on all the questions that are coming in. Sorry for the delay. We've got one. I have xanthelasma. Does this mean my arteries could already be blocked? Anyone like to answer that one? Any volunteers?
Yeah, I can cover that, Tina. So the answer is not necessarily. There's xanthelasma, as some people might not be aware, that's where you have cholesterol deposits around the eyes, not the stuff that you get in the colour bit of your eye. So these deposits that we sort of see around the eyes. There's an association between higher cholesterol and possibly blood vessel disease and the presence of xanthelasma, but nothing else beyond that. And so the presence of xanthelasma tell us that the individual should have their lipids measured, but it's not really, it wouldn't be true or fair to say that if you've got xanthelasma that you will have blood vessel disease, or that you're at particularly high risk. In the presence of xanthelasma, my advice would be to have one's cardiovascular risk assessed, because of course that means not just lipids, it means lipids, blood pressure, assessments of lifestyle as part of that. And within that, the presence of xanthelasma is probably not the most significant thing which would be associated with risk. There are other factors which are perhaps more concerning, such as blood pressure, smoking status, diabetes, family history, diet and lifestyle, perhaps more so, I would suggest, than the presence of xanthelasma. So the response to that should be check your lipids.
Great, thank you. Next question. For someone who has a raised cholesterol, not FH, how long would it typically take for changes in diet and exercise to start having a measurable impact on cholesterol levels?
I'll jump in on that one, and we usually say about 3 months to see if any of the diet and also gives people the opportunity to incorporate more of those dietary changes as well. So 3 months to see an impact on lifestyle effects.
Great, thank you, Lynn. There's a question on HRT. Would taking HRT after the menopause have a positive effect on lowering cholesterol levels and heart disease risk? Any volunteers?
I don't know the exact answer, but in reference to my previous point, we think that the lower levels pre-menopause are due to the levels of female hormones, particularly estrogen. So one would assume that HRT would help keep those levels down slightly. I don't think that, if you're at risk of cardiovascular disease, you should have your risk factors for that managed. I don't think that would be a deciding factor in terms of whether or not it's appropriate for somebody to take HRT. I think that other considerations would come into that. So it might help a little bit, but I think that the two things should be considered separately.
Thank you. How serious are abnormal liver function tests related to taking statins?
I'm happy to cover that, Tina. The answer is it depends. And so abnormal liver blood tests are potentially quite common. And the most important thing that probably needs to happen in the context of abnormal liver blood tests is an appropriate evaluation. That will often be done by somebody like Pete in primary care. And because it's such a common scenario, all healthcare professionals, all doctors, at least in this area, will be familiar with what to do. The risk of significant liver damage, as evidenced by severely abnormal liver function blood tests related to lipid-lowering therapies, is very rare. So the risk of significant, by that I mean life-threatening or permanent damage to the liver related to lipid-lowering therapies, is extremely uncommon. We occasionally do see slight changes in liver blood tests related to the introduction of statins, as well as a long list of other drugs which are metabolized, which are broken down by the liver. But that is not necessarily unsafe. However, because we do have this observation that rarely that we can sometimes see significant abnormalities in liver function, as the recommendations are to check them after introducing a statin. When we do see significant increases in liver enzymes, where it does seem to be associated with statins, we err on the side of caution, which will usually mean a strategy of using a different drug, changing the dose, etc., etc. But the likelihood of danger occurring to the liver related to statins, it is possible, but quite uncommon.
I think, Tina, the other thing I'd raise there, this becomes particularly important as people get access to their notes and can start seeing all their results. And when you start seeing your results, you'll see little red flags or little dots against all sorts of numbers on your results. So when we report a result, normal covers 95% of the normal results. So 5% of the results will come at either end, either slightly higher than average or slightly lower than average, and may be flagged as being abnormal, but they're still within the normal range the way we consider it. Now, why do we do it like that? We do it like that so that the clinician or whoever's reviewing the results can think about it and say, is that normal for that individual? It's the same as looking at somebody who might be 7'2" and play basketball or whatever else. That just means they're very, very tall. It doesn't mean they're abnormal or there's necessarily anything wrong with them at all. It just means they're very, very tall. So I think we need to be careful when we're talking about results that are abnormal. Are we talking about abnormal because this is a problem for the individual? Or are we saying they're outside what we consider to be the completely normal range, as in we don't need to think about it? Now, occasionally, even blood results within the normal range we need to think about, depending upon the person that we're looking at. And as I always say when I'm talking to people, I'm looking after you as a person. I'm not looking after a set of blood results. I'm using the blood results to help me look after you. I'm not using you to make your bloods look normal. So it's important to remember why we're doing them and what we're looking at.
Great, thank you, Pete. I think we've only got time for one more question. There's a question about lipoprotein little a. All we hear about is that it's bad to have a high level. Does it have any useful function? Dermot, are you still there?
Yeah, I'm still here. So the lipoprotein A is a little bit like the appendix of the lipoprotein system. So we don't really know what function, if any, it has and whether there might be any advantage. I to say to patients that it may have been that back in the day when you got your arm bitten off by a saber-toothed tiger, that maybe you weren't going to bleed to death so quickly if you had a high LPA, but unfortunately there's no real evidence at the moment to sort of confirm that. The only thing we can say is that people with high LPA seem to, for some reason we don't yet understand, have a lower risk of developing type 2 diabetes. So that's a little bit of an enigma that we don't yet understand. So it would appear that it's one of these biological kind of anomalies that we don't have a complete understanding of as yet. But there do seem to be differences between the outcomes of people with high LPA for other conditions such as the one I mentioned. My colleague Derek Rall, who spoke as the Mayant lecturer back in the Heart UK conference, has actually found that people with high LPA are more likely to have keloid scars. I don't know if anybody knows what these are like, but you can get overgrowth of scar tissue in a wound, and that this seems to be commoner in people of African heritage. But if you have a very high LPA, it may create a bigger scar. and his research suggests that there is more scar tissue formation on a wound in people with high LPA. So there's a lot more to learn, but what we do know that people with very high LPA certainly are at an increased risk of cardiovascular events, particularly premature heart attack, and therefore we're desperately seeking a solution to see if we can lower those LPA to, you know, the more average levels, or you know, certainly if we could get an LPA down to the population average, we would be much safer than if we have a very high LPA.
Dermot, thank you.
We got some of that.
We did, we got it all, thank you. The clock has struck 8 o'clock, so I'm going to wrap up this webinar by saying, on behalf of Heart UK, I'd firstly like to thank all of tonight's speakers for your wonderful presentations. I'd also like to thank our question moderator and specialist lipid nurse, Tina, for doing such a fantastic job with the questions. And finally, I'd like to thank you all for joining us this evening and for submitting your questions. I appreciate that not all of you will have had your questions answered, but we will do our utmost to respond and post any answers to the questions that have been submitted. I hope you found this evening useful, and if you would like any more information on anything that was being talked about tonight, or how Heart UK can support you and your family, or how you can get involved, then please visit our website at heartuk.org.uk. So thanks from me, and yeah, enjoy your evening.